Sure. Okay. So till ninth standard we covered that day.
Yes,
So
sir.
that was all the normal procedures and normal delivery, normal active management of third stage of labor, essential newborn care, and then respectful and supportive care we covered. So I hope you also uh, got the demonstration and hands-on experience
Yes, sir.
on all the things. So uh, uh, I mean, in that demonstration, we have also shown, Josna ma'am has also shown the demonstration on PPH compression techniques and newborn resuscitation, also kangaroo mother care, how to hold the baby in kangaroo mother care. So basically, these standards are left to cover, but yeah, we will cover it today so that you will get the better idea about it, what she has shown you in the demonstrations. Okay, so we will directly jump to the content. The 10th standard today will be the first standard today, and the 10th standard from the Manyata standard is postpartum hemorrhage. Okay. So the postpartum, if you have gone through the PPTs, you must have got the idea about the content in it. So we
Yes.
will you can also refer right now. Also, you can open that in your phone and you can refer the PPT if you want to, or if you want to have an interaction, it's fine. You can see it later on also. So the PPH PPH is postpartum hemorrhage. So, could you tell me what do we call for what we do call hemorrhage? What is hemorrhage?
Bleeding from
Bleeding, correct. So bleeding is a hemorrhage. So postpartum hemorrhage is what does it says? Postpartum,
post-delivery, the bleeding will
correct.
be
Post
bleeding
delivery.
will be called as
So we
postpartum.
have period like intrapartum, postpartum, and antepartum. So postpartum means after delivery there will be the bleeding. So that is called postpartum hemorrhage. But the thing is, there in every case there will be slight bleeding after delivery.
Delivery.
So will you call that as postpartum hemorrhage for every case?
No, sir.
Okay, so where should I demarcate that it is postpartum hemorrhage or the normal bleeding? What should be the demarcation point? Do you
The
know?
bleeding will be more than 500 ml is
Correct.
called
So bleeding will
PH.
be more than 500 ml. Uh, then only you will call it as postpartum hemorrhage. So postpartum hemorrhage, you said that 500 ml of bleeding. How will you identify it is 500 only? 500 or more or 500 or less? How will you
Uh,
identify that?
with the measuring of pads. With the measuring of pads.
Okay.
Count how many pads are
Okay. Getting soaked in how many minutes?
weightage.
Okay. So I will tell you the simple formula. I'm just asking the question what assessor will be asking to you in the exam. Like
Okay.
that I am asking. So questions will be like that. You just understand that. So I will tell you the simplest, formula for visual estimation. So basically, visual estimation for postpartum, for bleeding, I will say not postpartum. So, if we take the kidney tray, it is of half liter or 500 ml of whatever liquid. Okay, so um, we won't be keeping the kidney tray and counting the blood loss.
Yes.
It won't be there. But then from that thing, you can visually estimate that it will whatever blood is coming out will fill the kidney tray, and if it is filling the kidney tray, you feel that, so you should call it as a postpartum hemorrhage. This is the first thing. Second thing will be, you will, like you said, that you will you will hold the pad for packing. So at that time, that pad will get soaked within the 5 minutes. Within 5 minutes, it will get soaked fully. So if it is getting soaked fully in 5 minutes, then you also call it as a postpartum hemorrhage. Okay. And third thing, if you are not present at the time of bleeding, and you are coming after maybe 5 to 10 minutes, after taking care of baby, and you see that there is a bleeding on the bed. So if there is a spillage on the bed, so we consider it as 1,000 ml of blood loss. Okay. And if it is spilling uh, on the floor, we call it as 1,500 ml, 1.5 liter or maybe 2 liter of blood loss. Okay. So our body has 5 liters of blood. Okay, on an average 5 liters of blood. So if someone is losing 2 liter of blood out of 5 liter, then what will happen?
Maybe patient go into shock.
Yeah, correctly. So that is called hypovolemic shock.
Shock.
So what is the shock? Can you tell me what we call, what do we, I mean, what is the terminology says shock? Shock means what?
The pulse, it means tachycardia, low BP, and like hypo.
No, no, I am not asking the science. I am not asking the science. I am saying the general understanding of shock. What is
The
the
heart rate will be more, the BP will be down, the respiratory rate will be high.
Okay,
Patient
again you are telling
will
science, but
also be
I'll tell you
unconscious.
I'll tell you the general thing. It means that shock is what, that because there is a blood loss, the blood in the body gets reduced, and the major organ will start craving for that.
Pumping.
And also it may because of less blood supply to the major organ or maybe muscles, also to the whole body, uh, the body, the functioning of body is uh, is affected. Okay, gets affected. So yeah, so now tell me the signs. What are the signs of shock? How will you identify the patient is in shock? External signs. So you said that BP will be, blood pressure,
Low.
blood pressure will be dropped.
Yes.
Okay, and what about the pulse rate?
Heart rate will be increased. SpO2 will be low.
Okay,
Heart
SpO2 will be low, pulse rate will be high. Okay, and
patient may becomes unconscious.
yeah, what about respiratory rate?
It increases.
Okay, so what is the normal value of respiration rate?
16.
16 to 20. So it will be more than 20. Okay. Okay. And yeah, patient will be semi-conscious or unconscious. And what would be the condition of skin? Temperature.
Pain. Temperature will become low. Hypothermia. Hypothermia.
Right. Cold, clammy skin it will be. Okay. So now if you have identified PPH also, and there is a signs of shock as well. So what we need to do? Okay. So this is very important that nurses should know that how to manage this thing when doctor is not there, or maybe doctor is in different case, so that you have this time to utilize and save the life of the mother. So what nurses will be doing now, we are assuming that doctor is not there and everything has to be done by nurses. Okay. So the
The
thing
pressure should
is,
be applied.
yeah, so now one sister is only one sister is there available in the in the labor room, and other sister are like handling other departments, or maybe sitting at the reception. One is at IPD. So only one sister. Can one sister manage everything for PPH?
Need to help. Call for help.
Correct. So that she needs to call other as well. So shout for help is a first step to do. So shout for help is not only, I mean, to calling only sisters. You can call the ward boys. You can call other paramedics also. You know, if there is, they are free, they can come and they can at least help you in the things like, taking the box, taking the PPH box, or maybe holding the patient, or maybe putting the mouth gag. If someone doesn't know the cannulization, then don't ask them to do. But then other things they can do. Then if someone knows how to catheterize, even if he is a lab technician, sometimes they know it that how to catheterize. Maybe pharmacist also sometimes know. So you can call them as well, and you can take help. So shout for help is must. You first prefer the nursing staff, available nursing staff, to come over there in the labor room. Shout for help, you will need to take out the PPH box. What is like it is there. That PPH box is already there, and we have every thing in place there. So you are taking PPH box out. So one is, one nurse went to take the box. One is at the head of patient. One is at the abdomen side. One is at the leg side. So three people. What these three people will be doing? First, will be doing, putting mouth gag in the mouth, and um, taking out the secretion whatever is there. If there is no secretion, it's fine, but at least putting mouth gag. And then after removing mouth gag, if patient is in shock, then she will put the oxygen mask as well. Okay. So you should, you should be um giving the oxygen, administering oxygen at least 4 liter per minute, at the speed of 4 liter per minute speed. Okay. And then the second person who is at the hand side of the lady, uh, he or she will be doing cannulization. So cannulization will be of the 16 or 18 number of cannula. So why 16 and 18 only? Because the speed we want to maintain for this, the administration of fluid, we wish to maintain, or intend to maintain, uh, uh, is very much suitable in this type of cannula. So 16 and 18 number of cannula. Okay. So the flow we want to maintain is that. And the box we have made for PPH is for that purpose only, because many a times what happens, you need to search for the things. So here you will have everything in one box, and you don't need to run here and there for searching the items for which is required for PPH management. Same goes with eclampsia, and same goes with newborn resuscitation. So cannulization you have done. Now you first, the third person who is at a leg side will be doing catheterization. Okay. So catheterization, cannulization, and the oxygen thing is done already. So after that, what we need to do is, first is the fluid management. Fluid management is what you need to give blood is okay, but you first need to ensure that there is enough fluid you are administering into patient's body. So 1 liter of RL you will be taking, and you will be administering in from one cannula. One, so you have put 116 number on 118 number, or maybe both 16 or both 18. You can put it like that. And in one hand you will be administering 1 liter RL at fast speed. Fast means it should be finished within 40 minutes. Okay. Within 40 minutes, at that speed you have to adjust the RL. And in the second cannula you will be putting one RL with 20 international unit of oxytocin. So you will be mixing 20 international unit in that, and then this RL you will be adjusting at 40 to 60 drops per minute. Okay. So you have already given one uterotonic from the RL. 2 liter you are already administering, because we are considering that there is 1.5 liter of blood loss. And because of this thing, at least fluid balance will get managed. It's not the blood, but then the fluid balance of the body will get managed. So this is done. After this, there will be management of actual pph. You have already given one uterotonic in the RL. That is also for the management of pph only, with fluid balance. But now we have to go for actual management of postpartum hemorrhage. So what is the actual management? What are the types of pph? Postpartum hemorrhage, by what reason it can happen? What are all the types of pph? Do you know that?
Primary and secondary
Okay, primary and secondary is fine, but what are the causes in primary pph?
causes. Remaining of membranes in the uterus may cause
Correct.
many
Membrane, we call
cervical
it as a
tears,
tissue, or maybe retained placenta will be there.
and cervical tears also causes bleeding.
Cervical tears also, maybe some trauma also. Yeah,
And when uterus is not contracted when you
correct.
are
That is the major cause. Uterus is not contracted, tone is not there. It is called atonic pph. And the fourth reason is thromboembolic abnormality, that is bleeding time and clotting time abnormalities. So that is from birth, and that is that in that we can't help. We have to be ready for this patient to refer it to the higher center, or maybe arrange blood for them in advance. So there are four reasons. First is atonic pph, which happens in 80 to 90% of cases of pph. Okay. And rest three reasons are at 10 to 20% of the ratio. Okay. So those three reasons are uh, so here one formula is there. We call it as a four T's. Four T's. First T is tone, that is atonic pph, which happens 80 to 90%. Then second T is tear or trauma. Tear or trauma. And third reason is tissue. Tissue means, like you said, membrane remains inside, or maybe retained placenta is there. And fourth T is thromboembolic abnormalities. Okay. So those four T's are there. Then first we will see how do we manage for the first T. Okay. So the first T would be atonic pph. In atonic pph, what will you do to
giving
give her?
massage to the uterus
Yeah, give the uterus tone. You will give the external uterotonics.
body.
Uterotonics. Okay. So one uterotonic you have already used, that is 20 international unit of oxytocin. That you have already administered. So you just see if bleeding is stopped from that measure. I mean, you have already given 20 international unit, and bleeding is now reducing or maybe stopped. So no need to do anything after that, because you have already given one uterotonic and it is working. So you don't no need to use any other uterotonic. But in many cases it doesn't stop, or maybe just flow is reduced but bleeding is still there. So you can use three more uterotonic. That is called you must have used this uterotonic, that is called carboprost. Second is methargine, and third is misoprostol. Okay. So first is carboprost. Carboprost is contraindicated in asthmatic patient, and methargine is contraindicated in um, heart patient, or maybe hypertensive patient. So you have to use it alternatively when these conditions are present in some particular cases. So methargine 0.1 mg and carbapenem 250 250 mg, and this can be repeated. So the maximum dose of carboprost in the 24-hour is 5 doses, and maximum dose of methargine in a day is 8 doses. Okay. And at an interval of methargine maybe at 2 hours you can give, and carboprost at 4 hours. So if you feel that it is working but then bleeding again start, you can repeat the dose. After some time, if bleeding is starting again, you can repeat the dose. So these are the uterotonic. You can use the pause injection also if you have it. But then the guideline doesn't recommend you to use pause. But then even if you say pause MF in assessment, it's fine. They will not oppose you why you're using this. You can use it. Pause. Because now I think there will be an update on standards, and they themselves will add the pause injection. But right now it is not there. So you can tell that. Then if still bleeding is yeah, one more is there, that is misoprostol. Misoprostol 800 mcg microgram tablet. So generally we get misoprostol 600 mcg tablet. So what you do, there are 6 tablets, and you take another packet of it and take 2 more tablet in it.
600
And
mcg tablet is available, sir.
sorry,
Misoprostol 600 mcg is available.
600, that's what I'm telling you. So the thing is 600, you take 2 packet of 600 and divide, I mean take some tablet from that packet and make it 800 mcg.
800 total.
Yeah,
Will
800
we
and put
give one
it.
600 and one 200 like that?
Yeah, like that I am saying only. So 600, if you're getting 200 as well for 200 potency, then purchase it together. So 200 and one 600
ఇక్కడ
and
మనకి 200 ఉంటుంది 100 ఉంటుంది 50 ఉంటుంది 25
yeah. So a misoprostol tablet, you will be the recommendation to use it per rectal, because if you put it per vaginal, it will flow away with the bleeding. Okay. So the recommendation is to keep it per rectal, or maybe orally you can give, but then preferred route is per rectal, because it is more efficient or effective per rectally. So that is the thing. You can use this uterotonic, but if after this administering this uterotonic, it is not stopping, you can go for compression techniques. But I will tell you the compression techniques. Josna ma'am must have shown you the bimanual compression, then aortic compression, and then condom tamponade, how to make the condom tamponade. Have you seen it in
Yes,
morning?
sir.
Okay, so I do I need to repeat it, or
No
you
need, sir. We
you
understood.
got it, na? Yeah, yeah. So these 3 techniques are there, but the thing is, it's not only about atonic PPH. You can use this technique in tear trauma thing as well. Okay. So the thing is, most of the time, it is like not tear trauma, sorry, thromboembolic. Thromboembolic abnormality is there. You can use this technique in that as well, because you need to stop the bleeders. Uh, we will also see the cause specific management of PPH, what is there. But before that, I will, also recommend you to just go through the previous session where we have shown this. Maybe it was in Hindi, but still you will get it because it is demonstration. So you just watch that video as well. Okay.
Okay.
So
Yes.
the bimanual compression, aortic compression, and the condom tamponade you will be using in. Ek minute, you will be using in atonic PPH, thromboembolic abnormalities, and the condoms tamponade specifically. You can also use in tear or trauma thing. You need not to use the compression technique in tear or trauma. But the balloon tamponade or condom tamponade, you can use it in tear and trauma to stop the bleeders. So we will move to the second cause, that is called tear or trauma. If there is some tear during delivery of the baby, or maybe some trauma to some part of uterus, it may happen that it opens up the bleeders and bleeding start from there. So in this case, what you need to do is you just need to repair wherever you can see the tears in the uterus, or maybe external wall of it. You can repair it. You have to repair it. And for timing, you can give the packing. So packing can be done when trauma is there, when there is no clean cut. You can do the packing, and at the same time you can try the balloon tamponade, condom tamponade. And the third thing is tissue. So tissue is like tissue. Sometimes, since you are trying this uterotonics, so you while doing this uterotonic only, it contraction will start, the strong contraction will start in the uterus, and the piece may expulse out from that only. But the thing is, if it is not, then you can give external oxytocin, I mean extra oxytocin, maybe by IV or IM, and see if it comes out. If it doesn't come out, or maybe there is a case of recent retained placenta, so in that case you have to do manual removal of placenta or maybe membrane. So manual removal is done in expert supervision, or maybe expert will do. Expert is who? Your OBGYN. So OBGYN will do, and you just have to help them out. Or maybe sometimes you will do. If you know it, then you can do, but he should be or she should be there to observe or maybe to guide you. Okay. Or so if something happens, something adverse happen, then he will be there to manage it. Okay. So that is the thing. And the fourth thing, I have already told you that thromboembolic, we don't have any drug or any treatment for that. You just need to, you can just use the compression technique maybe for time being, or maybe balloon tampon. You can put balloon tamponade and refer the patient like that. So that balloon will be, you know, create tamponade effect inside the uterus, and by the time lady reach to the higher center, the bleeding will be stopped, and that can be managed at higher center, or maybe uh, you can manage it at your clinic as well, if your OBGYN is expert in it, in managing the things, like giving maybe some, I don't know, maybe it may stop by pause, or it may stop by other other whatever we use, tranexamic acid, or maybe uh, whatever we use for bleeding, it may work. So if your OBGYN is expert in that, he will do it. He will not refer him to her to higher center. But then now, since we are imagining that he's not there and it is happening, so you will just put balloon tamponade till the time your OBGYN comes in. Okay. So any doubt in this standard? This is the PPH. Any doubt here?
No, sir.
Okay, ठीक है. So we will move to the another topic, that is called eclampsia, severe preeclampsia, or maybe we call it as a pregnancy-induced hypertension. Okay, so this is the standard, which talks about the convulsions in pregnancy, the management of convulsions in pregnancy. So convulsions with proteinuria and the hypertension is called eclampsia. Okay. So because of this reason, also many deaths are happening. So because of that reason, Foxy has taken this complication on priority, and you nurses should know how to manage this eclampsia and severe preeclampsia. So according to the Foxy or maybe the WHO guidelines, you will have to manage it, and you should know the process to manage it. Procedure to manage. Before going to the procedure, I will just ask you the few questions. Um, if some lady is coming to me at before 20 weeks, she had hypertension. So what will I call this thing? She is in
Chronic
15 week, and she is having hypertension,
chronic hypertension.
chronic hypertension, correct. And if the lady doesn't had this thing, blood pressure in the first 20 week of pregnancy, but she came to me in 23rd week of her pregnancy, and suddenly I realized that she developed the hypertension now. She's having high blood pressure in two readings.
PNH.
PIH, right?
Pregnant-
So that is
pregnant-
what is full form of PIH?
Pregnancy-induced hypertension.
Pregnancy induced hypertension. And what if I say that with this hypertension, she has in urine examination, she has the proteinuria as well.
Proteinuria.
Urine albumin is present.
Eclampsia, severe eclampsia, pre-eclampsia.
Okay, okay. So very good.
Pre-eclampsia.
It is called preeclampsia. Okay. So preeclampsia. So you have said preeclampsia. Uh, at what point I will say that it is severe preeclampsia?
The proteinuria is 3 or 4 plates,
Yeah, correct.
and the blood pressure is more than 160, 120, or
Okay,
140, 90.
okay, okay. So suppose if one lady is coming to you, in this case that she doesn't have eclampsia or maybe convulsions. She has this thing. Only severe preeclampsia is there. That is 160, more than 160 systolic pressure, blood pressure, and 4 plus proteinuria. So what will you do in this case? She has come with labor pain, but you just realize that she has this thing, severe preeclampsia.
Eclampsia, sir.
What will you do?
We will monitor the blood pressure,
Hmm.
urine output, and
Okay.
any symptoms of like blurred vision and
Okay.
his.
So I will
And
ask you different question. Okay.
okay.
So patient with mild preeclampsia and severe preeclampsia. Two patients are there, and
Okay.
both are now getting convulsions. So what will you call these cases?
Severe eclampsia need to manage with MGSO4.
So it is eclampsia for both the cases. The case was in one case was in mild preeclampsia.
But both are getting convergence, no, sir.
Correct. So at any stage, when both when any case, whether it is either it is severe or
Preeclampsia
mild,
or severe
if
eclampsia,
if they are
patient is
getting
getting convulsions.
convulsions, then it is called eclampsia only. Okay.
Yes.
Okay. So I will ask you that you getting two cases, that one is both are in the labor pain, and one is in mild preeclampsia and one is in severe preeclampsia. What will you do?
Symptoms of
So two ladies are coming to your hospital, and one is in mild preeclampsia, one is in severe preeclampsia. So will you be giving same treatment to both?
yes, sir. We
Same
will
treatment.
monitor urine output. We have to give MGSO4. We need to give oxygen support.
So will you give MgSO4 to both of them?
Severe eclampsia, we will give MGSO4, sir.
Correct. That's what I want. So MgSO4 in severe preeclampsia, even irrespective of presence of convulsions or not, you will need to give the MgSO4.
MGS.
And before MgSO4, you need to control her blood pressure first.
And
Whatever drugs you are using, labetalol injection is recommended, but then it is not mandatory.
yeah,
You can
Depin
use
and Lavatal mostly we will use, sir.
so depend whatever you want to use, but then you need to first control the blood pressure, and then you will go for this thing MgSO4. Now, do you know the dose of MgSO4?
Yes, sir.
Okay, tell me.
Loading dose of 14 grams
Okay,
and maintenance dose of 5 grams each for the early.
correct. So tell me the division of 14 gram. How will you give it?
4 grams IV, slow IV with the dilution and 20 ml we will give here, sir.
Oh,
And
dilution in how many ml?
actually, 8 ml will be the MgSO4, remaining 12 ml will be
12
added in
ml. Correct, correct,
yeah,
correct.
20 ml we will give slow IV and each buttock 5 ml, 5 grams each
Okay, so
buttock.
that is done with 14 gram. And then what will you do after that?
The next, every fourth hourly, if we will give MgSO4 alternate buttocks each time, 5 grams.
Okay. So what
And
if
even though if the patient is needed adding dose of this thing, 2 grams more, we will give slow. So I
okay.
think so this is 2 grams will we give IV or IM, sir?
2 grams you can give IV or maybe IM also, but recommended is IV.
Okay.
Yeah. So tell me one thing. Before giving the maintenance dose, I am saying that urine output has been reduced. Also,
Yes,
the
police
respiratory.
catheter, we need to give the police catheter for eclampsia patients. And it is compulsory and mandatory.
Yeah, yeah.
And the
And the urine output is
output
less.
should
So will
be,
you give the MgSO4 in 4 hours?
sir,
I'm saying that I have given the 14 gram, the loading dose I have given, and after 4 hour, I am checking that urine output is less, it is reduced. So will I give the maintenance dose after 4 hour? I'm asking that.
we will give with the anti Lasix and all we
Lasix
will.
injection? No, no. What if I say that
Sorry, sir. The new release we will give Lasix.
respiration rate is less? If respiration rate is less, RR is less than 16, will I give
No, sir.
okay. And if knee jerk reflex is absent, will I give MGSO
No, sir.
loading?
No, sir.
So what
That
is
is
this?
one,
What
sir.
are these three things says?
One is respiration, knee jerk, and urine output. We will check. If it is abnormal, we should hold the maintenance dose.
Correct.
Otherwise, we can continue with
Correct.
the.
So that is these three things are called as toxicity signs of MgSO4.
Yes.
Yes, so you before you go for maintenance dose, you must check the toxicity signs and then only proceed ahead. So if toxicity signs are present and if all three toxicity signs are present, then you should hold the dose as well as you should also administer calcium gluconate that antidotes the MgSO4 in the body. Okay. But if only two signs are present, or maybe one sign are present, one sign is present, that is maybe knee jerk is absent, or maybe only urine output is less, then you can hold for 2 hours or maybe 3 hours. And then you can again, if everything comes to the normal, you can again give the maintenance dose. Okay. And till what time you should be giving maintenance dose?
Till the BP levels will come down. The
Uh,
blood should come up.
no, MGSO4
Maximum of
doesn't have
24
anything.
hours here we will follow up, sir.
So the thing is here you need to know that either you will give uh uh MGS load maintenance dose of MGSO4 till 24 hour from last convulsion. Okay, or maybe the delivery of the baby. If she is convulsing before delivering the baby only, then after delivery of 24 after delivery of baby till 24 hour from that time. Okay, you can give, but it's not mandatory that you should give it for 24 hour only. It's
Oh,
according to your clinical observation. You can give only two maintenance dose, and if patient is perfect, then it's
we
fine.
can stop.
Yeah,
Okay.
it's according to your observation, or maybe you're checking vitals and you are, if she's perfect, stable, then you can also withdraw it in 8 hours or maybe 12 hours also. Okay. So two maintenance dose give, and you can withdraw it. Okay. Again remain one question is remaining in this, that when should we terminate the pregnancy? At what stage, in what stage? So there is one chart in PPT, you just see it. This question won't be asked, but if some assessor asks this question, then you need to know this. Just only you will see that PPT, you will see that chart, but but before that, I mean, not before that, you just remember one thing, that if pregnancy is crossing 24 weeks, then it is crossing viable age of the baby. So at that time we are, you know we will try to save the baby, even if we are terminating. Okay. And if we are terminating before 24 weeks, then baby will not survive only. So at that time you will be telling the patient that, baby will not survive because of these conditions, and then you will be, you know doing the abortion kind of thing. Okay. So before 24-week termination will be, the termination will be no live baby. We will also, after 24 weeks also, sometime baby may not get saved, or maybe he will be like, yeah. So these things you will be informing to the patient and their relatives. Okay. Because of this complication. So that is done. Anything in eclampsia? Any question in eclampsia?
No, sir.
Okay. So now we will move to the third complication. That is, these two complications are in mother, and one complication is in baby. That we call it as birth asphyxia. Okay. So what is asphyxia?
Asphyxia కు మీరే ఆన్సర్ చెప్పాలి గైనిక్ అయితే
If we are
నార్మల్
unable to take breathe, then it is called, the breathing capacity is hampered, then it is called asphyxia. Okay. So birth asphyxia, what? Asphyxia is what? That baby maybe by any reason, there are many reasons, because of those things, uh, like if it is uh, prolonged labor, obstructed labor, or maybe fetal distress, or maybe, vacuum delivery, or maybe uh, cord around neck. Because of all these reasons, there are chances of baby having birth asphyxia, that is, he cannot breathe at the time of birth. Okay. So in this situation, what we need to do is, we need to, you know revive the baby again to the life, because if we leave him like that, he will die for sure. Okay. So to revive a baby, what we need to do is,
provide oxygen.
yeah, anyone wants to ask anything?
No, please.
Okay.
Sure.
So so if baby is not crying or breathing at the time of birth, and you are observing it that he is not crying, you have realized baby is not crying, what you need to do first is, do not wait for delayed cord clamping and cutting. I have told you in essential newborn care that there should be delayed cord clamping, but here you do not wait for that, because baby is not crying. If you wait for 2-3 minutes, then baby will be like Bhagwan ke paas. Okay, so what you need to do here, you have to clamp the cord and then cut the cord and take the baby to the warmer. Okay, so you are taking baby to the warmer and also taking out the baby kit. Now, here also, if two sisters are there, then one will be shouting for help. One will be going to the door and asking others to come to help. Okay. So now, what at least three people will be needed. So what will you do? One will clamp the cord and cut it. One will take baby to the warmer again. That lady will be taking care of the mother thing, whatever AMTSL and everything. But two people will be there at newborn corner. So after taking the baby, do you know about PSSR steps? PSSR. Have you heard of PSSR anytime? Formula PSSR.
No, sir. Sir.
Okay. So in this thing, the PSSR is very important. So now you are entering the golden minute of saving baby's life. So we call it as a golden minute. When you realize that, when you see that baby is not crying or breathing, the golden minute starts from there. So in half of that golden minute, what you need to do is to save the life of baby. You will be doing the things only. I mean, you are already doing it, but you are not doing it in a sequence, or maybe one or two steps you are missing out. Okay, every hospital does it. That is called PSSR. So the first step is positioning. So in the baby kit, you will see that we have recommended to have the shoulder roll. The shoulder roll works for giving
Yes, sir.
position
Shoulder.
of the baby. So shoulder roll is what? You will keep the shoulder roll below, you will put the baby first in the warmer and facing, I mean, the head will be at your side. Where you are standing, the head will be at your side, and you will be giving the position to the baby. What position it will be? It will be chest rise position. So to have the chest rise position, you will need to put the shoulder roll below the shoulder, so that
Shoulder.
the chest rise position will be obtained for the baby. Okay, you got it. Then second step is a suction, that is S. P is position, S is suction. Okay, so suction you will be doing by suction catheter. The first suction will be from mouth and the next suction will be from nose. So in mouth you will be, uh, putting the catheter till 5 centimeter, and in a nose till 2 centimeter in both the nostrils. Okay. So suction you have already done. Then the third step would be the stimulation. So for stimulation, you must have seen this in demonstrations.
Yes, sir. Yes.
Yeah.
Yes.
So the second S is stimulation, PSS. S is stimulation. So you just need to, uh, you know, put baby
Seven
in
legs.
left
Like
lateral
see.
position and give the stimulation like this. Okay.
One.
And the fourth step will be keeping baby in the same position which you given in the first place, like positioning, and R is repositioning. So the same position, chest rise position, you will need to put the baby. So you got it, PSSR, position, suction, stimulation, and reposition. So while doing these four steps, baby
Reposition.
may cry spontaneously at any step. At any step it may he may cry. So in that half minute only you will save the baby's life. So maybe because of mucus, he's not crying and you are suctioning it out, and then baby starts crying. Sometimes by stimulation it starts crying. Sometimes only giving position is enough, chest rise position, he spontaneously cries. So that is the thing. So he may cry anytime, but if he does not, then what you need to do is you again need to give him oxygen by ambu bag. Okay, so bag and mask is there. Bag and mask, you have completed the half minute of golden minute. ठीक है, 30 seconds. Now you have left with 30 seconds. If baby doesn't cry. But many a time, 50 to 60% it happens that in PA, during PSSR only, the baby cries. But if baby doesn't cry, then you need to go for
Provide the
bag and mask ventilation. In bag and mask, you need to have uh, two type of mask in your kit. So one is zero number, that is for preterm or maybe low birth weight baby, or the one number mask that is for normal babies or maybe normal weight babies. Okay, so first you need to check the attachment of the mask. So you need to cover nose and your chin, not your baby chin and baby's nose. Okay, and you need to hold it like in C shape. Okay, like this.
C.
C. After that, you will be giving one push and see if there is a chest rise. Like
Okay.
that, you will give 5 ventilatory breathe to see the chest rise is there. Okay, chest will be blown like this, so that you from that you will get confirmation that your attachment is perfect, and you are pushing the oxygen into the baby's lung, that is going perfectly. Okay, so now after this ventilatory breath, you have wasted the 5 seconds. Okay, not wasted, it is also utilized. You have consumed the 5 seconds. Now you have you remaining 25 seconds to give bag and mask ventilation. So bag and mask, you at what speed you will be giving? You just count one, two, and breathe. Then squeeze. One, two, squeeze, or maybe breathe. You can apply this kind of chanting. So one, two, breathe. One, two, breathe. One, two, breathe. One, two, breathe. Like this, you need to do for 25 seconds. It may happen that while giving this bag and mask ventilation, baby will cry uh, spontaneously. But you continue your 25 second and then remove it, uh, even if he cries in between. Like in 15 second only, he started crying. You just continue, you just complete your cycle and then remove it. But if baby doesn't cry, even after 25 second, or maybe he doesn't breathe, then what will you do? At this stage, you will be just checking his cord pulsation. You need to check his heart rate. Okay, so heart rate should be 100 per minute. So you don't have right now. You don't have time to check it for 1 minute. So what will you do if it is 100 in 60 second? Then you will just check it for 6 seconds and see if it is 10 in 6 seconds. If it is 10 in 6 seconds, then it is fine that you have done a good job, that even if baby is not crying or breathing, his heart is regulated, his heart is working. If his heart is working, then you continue your bag and mask till the time he cries out, or maybe your pediatrician comes in. Okay, till the time you just keep giving your bag and mask ventilation. And if baby doesn't cry or breathe, or maybe he may not have the 10 uh, uh 10 pulsation, 10 chord pulsation in a 6 second, so then it is the problem, because baby's heart rate is reducing. That means that his heart is decreasing his functionality because of these things, because of maybe breathing problem or maybe whatever. So at this place, what you need to do, you have to attach your oxygen cylinder um, to the ambu bag, and continue giving the bag and mask. So the speed should be 2 liter per minute for the baby, and till the time pediatrician comes in, you need to administer that. Okay. And yeah, I forgot one steps to follow, that while calling for the people, one people will also call pediatrician to see the baby. And by the time he comes in, you will be doing this procedure. Okay. So anything in this? Anyone wants to ask any question? No question?
Please ask some questions like how assessor will ask so that at least we will come to.
Okay. So the first question will be like, one baby is born and he's not breathing or crying. What will you do? Okay, so the ideal answer should be you will be taking a baby, you will be performing delayed cord, not immediate cord clamping and cutting, not
So
delayed.
directly they will ask a question like this, means we can
Yes,
we
yes, yes,
will, we
like
will
this
go
only.
for the cord clamp, the cord cut, clamp cut,
Yes,
and
yes.
we will
So,
use the
no,
plumber.
no, no. Your answer should be, this is called birth asphyxia, and now we will have to, revive the baby. That's why we need to do the newborn resuscitation. And
Okay.
so then he will ask that what is newborn resuscitation and what steps will you follow?
Okay.
So first PSSR, then bag and mask ventilation, and before that you will be also shout for help and call pediatrician. So
Okay.
that's it. That's it. And also after he will
Need
ask,
to explain all the steps one by one, sir, to the assessor.
sorry.
We need to explain all the steps to the
Yes,
assessor.
yes, yes. You go on. He might interrupt you in between. That
Okay.
why you're doing this? Tell me. Why
Okay.
stimulation? So you
Okay.
need to know the logic. Stimulation, by stimulation, we just, give this warming thing, and his lungs start functioning, and then he start breathing or crying, or maybe by suctioning, you are extracting the mucus out of his maybe mouth or nose, like that. He may interrupt you. Or
Okay.
maybe you can, it can happen that you may miss any step in between, and he will interrupt that, what before this. So
Okay.
you will just then remember and recall the things, and you will tell, like that. Or maybe sometimes, after doing bag and mask, he will ask you that, how will you ensure that you have done the good bag and mask ventilation. So you will tell that you will check the heart rate, and
Just
yeah,
raising and all.
yeah, like that. So the
Sir,
question,
the question answers will be coming from only from these six sessions or extra also they will ask.
sorry.
The assessor will ask the questions only from these sessions. What this from this 16 uh,
Yeah. No extra question will be there. This will, questions will be from this 16 point only, not extra questions will be asked. But and even if he asks, he doesn't score that. I mean, you don't have to do anything with the extra things, because there are criterias and he has to give the marks. So even if he has some different question, he doesn't have provision to give the marks to that questions. So it's fine. You should know these things. Otherwise, if he ask anything extra, and you don't know it, it doesn't matter, because it will not reduce your marks.
Sir, all the two sessions you have taken in English, sir. From other hospitals also attended the sessions. By your question answer, if, when you are taking sessions, by your questions, what may be our your what to say evaluation about answers? Is that okay, fine, or we need to improve so much?
No, yeah. So I'll tell you that, I'll compare you to this batch only. So,
Okay.
whatever I observe, like, see, there are things that, few things you may miss out something. But the important thing is you need to be very proactive. That
Okay.
is there. And at your hospital, I'm seeing that everyone is listening carefully and everyone is noting it down. Likewise, I just also want to, like, you are only talking, so I also want to hear from others. So if others can speak, because, only point I want to point out. Otherwise, it's all good, because your hospital is very punctual, also very attentive. And what matters is, you need to be very very proactive at the time, and you should support each other. Like sometimes what happens is, you are telling the answer and you are missing out some things, and
The other person should know.
yeah, other person should tell that, I want to add after you
Okay.
after you finish talking. So
Okay.
I see that coordination in you, because this thing
Okay.
only create a chaos around, and you can do it. I mean, it's good.
Sir, will the officer choose the person to answer or anyone can answer, sir?
Sorry.
Will the assessor choose a person to answer the question or anyone can answer?
See, anyone can answer like that. It happens only. But the thing is, like now you are how many people are there? You are sitting 7 to 8 people are there.
Yes.
But every answer, if 3 people are only talking and 5 people are quiet for longer time, then he may point
Ah,
out. He may point
okay.
out someone that you don't tell now. Let her tell. So like that. So I will also give a trick for that. So what will you do? You just need to distribute the topics.
That's
So
all. Yes.
according to the potential of the person,
Question?
or
Yeah.
maybe interest of the person. Maybe some people are having interest in PPH, some people doesn't know about NBR. So you just distribute it, and whenever that question comes in, no, that person will tell. So assessor will not feel that one person is
Okay.
not talking.
Agreement.
One person is not talking, everyone is
I
talking.
will give
Even
one
if it is
chapter
hand
per one
wash, even
person.
if it is hand wash, like one person is very weak in your group. I mean,
One
he's
step.
not weak, but he's not vocal.
Okay.
Maybe he knows the thing, but he's not vocal and he's shy. So just give him a simple topic like hand wash, and he will
Okay.
he will she will tell that, and then keep quiet. Or maybe some toxicity science or chota topic you may assign to her, because she can't talk for a longer time. So give her chote topic, and then she will be also noticed. So
Okay.
like that, I'll give you this tip for assessment.
Anything to any suggestions you can give me, sir, so that we will follow during the assessment.
Yeah, yeah,
Any
definitely.
suggestions?
Definitely, I will give many instruction before your assessment, but I just wanted to
Okay.
finish your content first, and your mock also will be there. I will also get the recommend. I mean, whatever feedback from that, and I will connect you once after the mock assessment, and before your assessment, I will be telling you many things. I will not tell these things now because you will forget it. I will tell it like when there will be 1 week gap for assessment maybe,
Okay.
so that you will follow
When
those.
we are going to have the revision is done now, sir?
Few topics are there, like you already seen the kangaroo mother care. You already know the infection prevention practices.
Yes.
Do you know about Robson's classification criteria?
What is it, sir? I don't know.
Robson's classification criteria, it is 16 standard of Manyata.
Okay, no, sir.
You don't know, right? So that's what
Yes, is what the reason cesarean section will be happens is the question, sir.
yeah, yeah.
Yeah, okay.
So, yeah, so LSS, to reduce the LSS rate, the classification criteria is introduced, and Foxy recommends hospitals to, use this classification criteria and audit LSS cases
This will
accordingly.
be followed by doctors or the sister should be involved, sir.
Sister is involved in classification, but the audit will be done by doctor.
Doctor. Okay, sir.
Yeah,
And they will ask the question to sisters only.
sisters, yes, because they should know the groups. To
Okay, sir.
divide it, they should know the groups. So
Okay.
yeah, I'll tell you. So I'll before that I'll also ask you that uh, um, you are well aware about postpartum care package.
Package.
So basically, I will just keep the kangaroo mother care and infection prevention practices. I'll just in infection prevention practices, I'll just ask you one question that do you use hypochlorite solution for cleaning, or do you use bleaching solution?
Hypochlorite solution
Okay, so
and
you have
plastic.
it, so it's fine, but only recommendation is that before sterilization of the used instrument, the processing should be done by dipping the instrument for 20 minutes in hypochlorite solution.
Yes.
That, do you follow that?
Yes.
Yeah, okay, then it's fine. Then if you're already following it, and then you will tell it. So that is the only thing. Also, the biomedical waste, right?
Yes. Yes.
Yeah, so that is the only thing, that hand washing and everything they will ask, PPE, personal protective equipment, and infection prevention is done. Kangaroo mother case is also done. So
Yes.
I will go to postpartum care. Postpartum care package says tells about um examination of baby after delivery of baby. There will be 2 hours which we call as fourth stage of labor. So in
Yes.
that fourth stage of labor, you need to extensively check both of them, baby and mother. So in baby, we check temperature, we check skin color, we check cord stump, we also check eyes, we check sucking reflex. Then we also check anal opening, if he has passed the stool or not, if he has passed the urine or not. All these things we just check. Okay. And then also we teach them about breastfeeding techniques. So breastfeeding technique is a proper attachment. You just need to check the proper attachment, and you just need to tell the tips how to breastfeed and what is importance of breastfeeding and at what interval she should do. Also in the mother, you will check the breast is engorged or not, her vitals, then if there is a episiotomy, then the sutures, then the also you will check the foul smelling discharge is present or not. Also you will check you will check the contraction, then maybe tongue of the baby, tongue of the mother. Uh, then you will also uh, check the temperature. So basic things you will be checking, but the thing is, only thing here is postpartum care is for 2 hours you will be checking it half an hourly, and after 2 hours, after shifting her to the ward, you can follow your regime like in 4 hours or maybe 3 hours, whatever your regime is. But then you need to check these things. With this thing, you need to also counsel patient on the family planning. So you just need to tell her the option for family planning. Family planning means it's not only about the family planning operation, it's also about the spacing methods, it's also about the barrier methods, it's also about the temporary technique for not to get pregnant again in within a year, or other measures to tell. And in this discussion also involve her husband, so that he will also get an idea about it. Also, in our Indian society, husbands are main decision makers. So if you involve him, then lady and husband together mutually they will be able to take the decision. So that is the thing. Also, it is recommended to show them some visuals, like if you are showing OC pills or maybe copper tea. So just show them on YouTube, or maybe if you have some posters, you can just show her, and then uh, practically they will get it, and then they will decide accordingly what they need to do for the spacing or maybe the permanent sterilization. So that is the thing in family planning counseling. Second counseling will be on nutrition and hygiene. So nutrition is like, you already know that what things she should be eating and for what purpose. So you just need to convey the message that if you green leafy if you eat green leafy vegetable, then you will get iron or whatever. So you will just need to explain this thing. Also about hygiene, so how to maintain, maybe uh, vaginal hygiene, or maybe baby's hygiene, or personal hygiene. So accordingly, also before breastfeeding, what should be the hygiene maintenance and other things. Then third point here is the counseling on postnatal depression. So many a times, many cases in India, it is proved that 30 to 40% of cases goes in postnatal depression after the delivery.
Yes.
So in that case, you just first need to ensure that she should not go in postnatal depression. But if she does go, then you need to counsel her accordingly. Whatever the reason is, if she's feeling very low, or maybe because of gender, she's feeling that depressed, or maybe because of other things like family pressure or something,
Postnatal changes.
or maybe because
Sir,
of
can you please explain us about chapter 16, sir?
yeah, yeah, I'm going to
Below
that
the
only. I'm going to that only. So chapter, I'll just finish the 15 postpartum hemorrhage, 15 chapter. So you need to what I was telling, postnatal depression. So postnatal depression, you will be explaining, you will be just counseling her on postnatal depression, and don't be judgmental, or don't be give her like friend like environment and family, like she is your family, or maybe she's at her homely environment, give her. And then postnatal depression can be recovered. So we will jump to 16 standard. So 16 standard is the Robson's classification criteria. And if you can open the PPT, you will see that there is a chart given of 10 groups of uh, C-section classification. Or should I open it?
yes, sir, please.
But in this laptop, I don't have it. एक minute, I'll just download it from WhatsApp, and then I will. So the sixth sixth session, sixth clinical
Discussion? Yeah.
sixth clinical
Slides, sir? Okay.
Yeah, you got it. I will just try to download it from WhatsApp, and if I can present it. So by the time I will just tell you.
Okay.
Um, yeah, it has opened. Ek minute, just give me the.
అన్ని తీసుకురామని చెప్పండి లోపలికి సి సెక్షన్ క్లాసిఫికేషన్ అని చెప్పి ఇచ్చిండు సిక్స్త్ దాంట్లో నైన్టీన్త్ స్లైడ్ నుంచి ఉంది స్లైడ్ నుంచి క్లాసిఫికేషన్ ఆఫ్ డెలివరీస్ అని చెప్పి హౌ టు క్లాసిఫై డెలివరీస్ ఇది నాకు కూడా రాదు ఈవెన్ ఇప్పుడు అంటే తెలుసు కావచ్చు కానీ ఇట్లా క్లాసిఫికేషన్ చేస్తాను మా ఒక్కొక్కరు ఒక్కొక్క చాప్టర్ పంచుకోండి వీటిలో లేదు లేదు లేదు
Just give me 2 minutes. I'll open it. Okay, can you see it? I put it on presentation mode. Okay, so this chart, can you see it?
Yes, sir.
Okay, so this chart, see, we are just dividing the C-section cases into 10 groups. Okay, so
Okay.
now since you can see it on a bigger screen, is it like that? You have bigger screen?
Yes, sir. Yes,
Can
sir.
anyone see the everything written over here?
Yes, yes. Available, sir.
Okay, okay. So the if you refer to the group one, uh, it says that nulliparous woman with single cephalic pregnancy equal to or more than 37 week gestation, weeks gestation in spontaneous labor. Okay. So the cases which are like full term, and she is primarily Paris woman with vertex presentation. Everything is normal. Uh, Contraction was also there, but for some reason you took her for LACS. That's why she goes to group one. Got it?
Yes, sir.
Okay. So the pictures, see the picture now. So the baby inside the mother is vertex, and she doesn't have anyone standing behind her. So she's primary. Okay.
Huh?
And you see at the right side of, or maybe right, you are also, it will be right only because you will see like this. At the right side of abdomen, it also has the vibrations. So vibration says that it has a contraction and pain and dilatation. But still, because of maybe, you can say that maybe patient herself, client herself want to have the cesarean section, or maybe sometimes hospital, what hospital does is, because normal delivery has less charge, and if you do LSAS then you will get more charge, so that then because of finances, they also do it. Sometimes there are other reasons like, a meconium past or maybe fetal distress. At that time also, even if everything is present, you take her to the uh, LSS. So this kind of cases goes to the group 2. Okay? Sorry, group 1. And group 2 is again nulliparous woman. Everything everything is like group 1 only. Here only thing is uh, this you can see from 1 and 2 picture, you can differentiate that there is no vibration. So here the lady is nulliparous primi. Everything is normal, full term and vertex presentation, but she doesn't have the contractions. She doesn't have the pains. So in this case, you have tried maybe augmentation or induction, but after that also nothing progresses, then you take her to the LSA. So these kind of cases goes to the group 2. Group 3 talks about same like first group. First group it is like that only, but only difference here is she is multiparous. She is she is multi. First one is primary. The third one is multi. Everything is good. The first baby was also from the normal delivery only. It delivered by normal delivery only. But now you have taken her for LSCS. Okay, for any reason. And group 4 is also like group 2. Multiparous, everything is normal. and first baby was from normal delivery only, but now she doesn't have the contraction. That's why you have taken her for LSCS or maybe planned Caesar it is. So group 3 has this. See, if you see the picture of group 3, then one baby is standing behind her. So she's multi. And she has, and at left side she has that vibration, so that is contraction. Group 4 has baby standing behind, but there is no contractions, no vibrations, so that is group 4. And group 5 is previous LSCS. Group 5 is previous LSCS, so the baby standing behind has the C mark. So in this case, it is recommended that if previously it is pre C section, then you should go for C section only. Okay. So these only these four group we can convert to the normal delivery. After five groups, fifth group, we can't do anything. After fifth group, we just have to take them to the LSS only. So I will tell you the 6, 7, 8, 9, 10 group. So 6 is the bridge presentation. Okay. But she is primary. So you can see that baby is ulta. Baby is at buttocks position and inside her womb. And she doesn't have anyone standing behind. So she is primary. And the seventh group is baby is ulta, but one baby is already standing behind. So she is multi. So primary with bridge, multi with bridge. Group 6, primary with bridge. Group 7, multi with bridge. Group 8 is twin pregnancy. Okay. Whether it is primary or multi, twin pregnancy goes for LSCS only because it is a high risk pregnancy. Okay. Then group 9 is the transverse or oblique lie. Okay. So it is also a malpresentation. If malpresentation is there, then it is also recommended to have C-section only. Okay. Then group 10 is small size baby or maybe preterm baby. Okay. So it might be the full term also, but the LBW baby. So a preterm baby has a less weight. That's why it is recommended to have the LSS to save the life of the baby, because it may happen that he stopped breathing or crying after delivery. If we deliver it normally, if we try to deliver it normally, वैसे तो it will be difficult to deliver it normally because the size is small. So because of that, we have taken them to LSCS and we are dividing this 10 group accordingly. Okay, so understood, or you want to ask anything? I will tell you the further steps to it, but you just tell me on this if you understood or not.
Sir, hello.
Ah, yeah.
Now we got an idea, sir. That is what is.
Yeah, so now you got an idea about 10 groups. So what you need to do, you need to prepare one chart. Okay, one chart where horizontally you will write the month of the year, and
Okay.
vertically you will be writing the groups 1 to 10. Okay, and you will be writing in particular month how much from from which group. So from first group there will be 3 cases, from second group there will be 4 cases in the month of August. uh, and then in third group there will be 2 cases, whatever it is. You just figure it out and you feel it, and after 3 months you will have to do the audit of it. So audit should be like, after 3 months, audit should be like from fifth to 10 group, there should be more percentage than 1 to 4 group. If the percentage is more in 1 to 4 group, then you need to, recheck your strategies for the LSAs and normal deliveries. So you need to, basically you need to reduce this 1 to 4 group ka ratio to the 5 to 10 group ka ratio. Got it?
Yes, sir.
Yeah. So that is about Robson's classification. Okay. And with this, you also need to have your OT set ready. your OT ready, everything like newborn corner and everything should be present in OT. Other posters, essential posters should be.
Sir, we have labor room in third floor, sir, and OT is in -1. That day, will the assessor will check the labor room and OT also, sir?
No, he might go to LR, labor room, but not to the OT. But yeah, he will
Okay.
ask you that where is the OT. So it is at ground floor.
-1, yeah.
Okay, and the labor room is at first floor.
Third floor.
Sorry,
Third floor.
third floor. Okay, so how do you transport the patient if you want to, like आपने try करके
Whenever we
देख लिया,
have a
you
labor
have
case,
tried, you
mm,
have tried, and some emergency comes in, like some you see that some antepartum hemorrhage is there. You are taken the patient to the labor room. Then how do you move it quickly?
immediately with the security and PR will coordinate and they will hold the lift and they will arrange the stretcher and we will shift immediately to the OT. The
Okay.
OT also will be there.
Yeah, so this is the answer is expected when he points it out, that
Okay.
how do you manage the cases. So it is not mandatory to have it on the same floor. It is not also he will not see the OT. He will just ask you that where is the OT,
Okay.
or he might not ask also. It depends on assessor. So like that. But then if he asks you or he points out, then you have to justify it. You have to tell that. But Manyata doesn't say that, you have to change the structure of hospital, or yeah, like NABH, it doesn't say that you have to change it or you have to reconstruct it or like that. So it's not necessary. It's not mandatory in Manyata. In whatever setup right now you are having, you have to manage the things like that. That only Manyata says. So that is the thing. Yeah, so we are done. Anything you want to ask more? Just be prepared with everything. I'll be sharing some posters with you. You just
Okay, sir.
stick it to the appropriate places. I will be sharing after this class or maybe after 2 3 days after
Okay, sir.
everything gets over to the everyone. Uh,
Okay.
and you just take
Sir,
prepare.
when may be the approximately assessment will be, sir?
It will be I think from 20 to 31st August. Any time between 20 to 31st August.
The 25th to 31st August, sir.
20 to 20, 20th to 31st August.
Okay.
Yeah. You will get the mail, or maybe you will be communicated directly by the Josna ma'am, because
Okay.
CSC hospital gets that information. But we will not be there. The trainers won't be there in the assessment.
Okay,
And that
sir.
will be done by different people altogether. We will only get the information of the assessment and the link for the assessment to join and everything. We will get that information, but then not the access to the assessment.
Continue,
Okay, so
sir.
I think we will keep your queries ready. We will
Okay,
again
sir.
connect once after your mock assessment, so that I
Okay,
will
sir. When
also
will
give
be
you
the mock
feedback.
assessment, sir?
We will conduct your mock assessment in next week, I think. I will not conduct this. I will, Dr. Nidhi will be there.
Okay.
Yeah, so she will conduct your mock assessment. And from that, I will get the feedback from her. And accordingly, I will connect
Will
with.
you inform prior only, sir, which day you are at, taking mock assessment?
That you need to ask Josna ma'am, because she will
Okay, sir.
schedule it. And because she coordinates with Dr. Nidhi. So
Okay.
she will schedule. It's not only for you, it will be for all. So accordingly.
Altogether, one day they will take mock assessment.
Yeah, that will be mock assessment will be like the final assessment. That
That
will
is what, like individual hospital you will take or altogether like group.
individual. No, 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 no. It will be individual. But the thing is, she will be taking it like in morning, she will be taking Matrutva hospital. In afternoon, she will be taking care hospital
Oh,
like that. So that schedule Josna ma'am will decide in coordination with her, and she will share it with you, or maybe on the group. You will get it.
Please give suggestion to Joshna madam that sir, please inform us priorly, because if someone is there on leave also, we will coordinate and we will cancel the leave and we will be on duty.
Yeah, yeah, sure. That will be done. That will be after coordination with that assessor and as well as you.
Okay, sir.
Yeah, yeah. That's not the question, because yeah, we need to check your time as well.
Okay, sir.
Yeah, but Foxy assessment won't do that. Foxy assessment can
That
be
won't
anytime.
be. The
That
final
can
date
be.
will be announced now,
They
sir.
will
Which
not.
will
They
be the
will not
final
ask
assessment.
you for your convenient time. They will
No, no,
schedule it.
no. We will know. We will come to know the date. Which day will be the final assessment before only, no, sir.
Yeah, yeah, yeah. That you will get.
That is
That you
only
will
it
get
is
before
enough.
maybe a week or maybe 10 days before also. You will get it.
Okay, sir.
Yeah.
Okay, sir. Okay, sir.
Yeah.
Then thank you so much, sir.
Yeah.
And
Thank you.
we'll
Thank you. I will also
session.
upload this recording. You can.
Yes, sir. Please send us in our group, sir.
Sure, sure, sure.
Thank you, sir. Thank you so much.
Thank you. Thank you. Bye bye.
Bye, sir.